So hopefully you can see my screen, just tell me, and I have nothing to disclose. And yeah, go back. I'm going to talk about some intersections of medical care and behavioral health care. And yeah, this is as much for me as for everyone else. We have such an extraordinary agenda today with so much on gender. It's really wonderful to follow. Tandy, congratulations on your professorship, Tandy. That's great. So I want to look at key issues today. Just, the interdisciplinary model for care is, I think, actually important for all care, not just gender care. And in thinking about how to provide patient-centered, gender-affirming care, I'm going to go into thinking about gender. Now you've had two people already explore gender, and we're going to keep on going. So this is a bit of a review, but a slightly different approach as we think of ourselves and the people we know and love, and as we journeyed from youngins to the present. What is that internal sense of self? So it's bodily knowledge, it's knowing what's happening. It is also expression as we kind of learn what it's like to express a gender or gender identity, that internal knowing. And I'm going to use the word interoception, which is that internal sensing. And this is something I think I'm hoping that gender providers, both mental health and medical health folks, will encourage people to try to sense into. Then there's also our body, chromosomes, and thank you, Hans, for your sharing there. There's our genitals, that the sex assigned at birth is often a term that's used, our hormones, our secondary sex characteristics. And then there's how you feel or express and how you are perceived. So that two-way arrow there, which includes roles, clothing, hairstyle, mannerisms, language, and what is expected of us. So that's kind of a framework similar to what Tandy shared. And this is a way you may often see it as well, not just the abacus, but that gender identity in the center, sex assigned at birth, how we express, and then how your gender is perceived by others. So rather than use the word transition, which is often used as folks are on a gender journey, Bob, and I meant to put Callum's name on this PowerPoint as we had journeyed on this thought process together. The term came to us about 3 years ago as we were preparing for a presentation for Gender Spectrum. And the term trans embodiment came to us, and it was absolutely from our experience, our own experience. And then we began to see the word embodiment everywhere in relation to gender care. But so it's that process of bringing into one's internal awareness and knowledge into authentic presence out into the world. Where does that self-awareness come from? And these are the things we came up with together: alignment, a process of finding comfort and trust, then that sense of mismatch between what you see and how you feel. What feels right? Like we talk about gender dysphoria, but what about gender euphoria? Something that feels right and desirable. And then that dysphoria, which is talked about more often, the discomfort or just distress or depression. So knowing ourselves, this is something I'm really hoping that I can, or we can, bring forth more with our young people and for everyone, really. That sense of self that you have that's reliable, that the feelings you have are true and valid. Mirroring, that really, we have known about that in psychology for quite a while. And then without these things, one has trauma and dysphoria, with isolation and helplessness. And so self-actualization and embodiment include social things like changing your name, requesting for the pronouns that are right for you, sharing with your friends and family and school, and your clothing and appearance. There are medical interventions, and we can talk about some of those today. And then there's legal and insurance processes. And so we're going to be using self-actualization or embodiment rather than transition, because in fact, transition implies kind of A to B, and oftentimes we don't really know where we're going, or we've always known where we're going. And so it isn't really a transition. Echoing what Hans has said, trans health actually has been authored by cis persons, and it's a challenge actually to be a trans identified person doing this care, because so much of it feels pathologizing, is pathologizing, and isn't particularly accurate. For example, gender dysphoria has been a requirement in our diagnostic statistical manual in order for transition or embodiment to occur, but not every trans person has dysphoria. So this is a refrain that many of you have probably already heard about: nothing about us without us. And so there are some trans affirming medical resources. It's still a process. And so I think these slides will be available to all of you, but here are some resources for you that are becoming more trans focused. The World Professional Association of Transgender Health, and I forgot to start my timer, damn it. Okay, I'll watch. The version 8, which should come soon, has many more trans persons involved in the writing of it. But in general, it's still problematic. So when I prepared this talk for Marcia's class, I kind of focused on 10 different things in this intersection between medical and behavioral health for trans and gender expansive persons. And I won't talk about all 10 because I can't do that in a half hour, but we'll talk about the rise in non-binary identities, the impact of microaggressions, and how important it is to address those. I won't talk about the importance of primary care, but believe me, it is important. I won't talk about eating disorders, which have a higher prevalence or have a high prevalence in trans and gender expansive persons. I won't talk about this rainbow double helix between neurodivergence or neurodiversity and gender expansiveness, but it is there. Navigating intimacy, I won't go into great detail, but that is quite an interesting and important issue for medical providers and mental health providers to support folks with. Sexuality, I'll just touch on. Contraception, just a moment. Fertility will be talked about later today, so I won't talk about it, and we won't have time for surgery. But just this is a sense of kind of the top 10 right now. I'm sure it will shift. So this is really, if there's nothing else from my talk today, this is what I want to emphasize, which is we cannot do this work alone. We need to support our clients and have them in the center. And then we, as in all of our different arenas, communicate with each other and with the client. So non-binary gender identities are definitely increasing. This was already in 2015 with our US Transgender survey that 35% of folks were identifying as non-binary. Some folks have more than one gender identity or are fluid, but this is really important for you to know and kind of watch. So again, from this data from 2015, there's a recent article that just came out in Pediatrics where they did a study with teens, and over 9% of the teens did not identify with a binary. They may not have been trans identified, but that's a pretty impressive statistic. Usually it's in the realm of 2% of folks that identify as trans. Some studies suggest a higher risk for suicide and depression and anxiety. And that makes sense, given that our society is structured around binary identities. And when I share my pronoun as Jen, not as he or she, they is okay, but typically people just forget it in an instant, doesn't really land. And so it's a sort of constant coming out process. That said, there is a legal status recognized in some states. The state of California is one of them. And we have limited research, but that is increasing. And there was a special issue in the WPATH journal in 2019, and there are more research happening, thankfully. And this is just noting that in 2019, January 2019, one could get, and I have my non-binary driver's license. The gender marker is an X. And care for non-binary individuals is, I think, finally getting recognition. We don't have a non-binary hormone. You cannot select secondary sex characteristics, although I'm actually confident that at some point in the future we'll have that ability. We'll understand receptors on hormones better. But this is an important area of research and care. Moving to microaggressions, you may have heard the term before. These brief, commonplace exchanges that don't seem harmful on the surface, but in reality express power imbalance and suggest the inferiority of marginalized people. That's from Frances Walker. Also from Julia Serrano, an important theorist, that microaggressions are a reminder that cisgender people maintain power and control. And those seemingly small slights lead to much larger consequences. And this may be why, in fact, even with gender affirming care and embodiment, anxiety often remains. And I think that's because of that continued cissexism and microaggressions. So here are a few images. You look just like a woman. And what that feels like is that trans women are truly women. And this, I actually heard a fellow provider share this with a patient, and it goes down deep. It doesn't feel good. It's so hard to switch pronouns. I hear that all the time. And then what it really feels like is you're just an inconvenience. Like, why are you making me do this hard work? And then, you know, just what it feels like when you're addressed by the wrong pronoun. It's small, but it has a large impact. So if you make a mistake, and hopefully you'll notice, this is a recommendation from Jamie Campbell. The CPR, C for calm yourself, practice humility, and repair, which starts with an apology. And then you actually need to slow down. That's probably the most important thing to do, is to slow down before you speak, especially when you know that you're working with someone whose pronoun may be different. So this is something my older kids now are talking a lot about. Prioritize impact over intent, which means a lot. So, you know, instead of saying, well, I didn't mean to, like, acknowledge, I did that, apologize, and then do the work to repair. It's not about who's right and wrong, but it's really making a commitment to being better and to justice and equity. So how do we provide gender affirming care? And I apologize, this is going to be a long list, and that's the big no-no with slides, but bear with me here. So it is extremely important in your, wherever you're working or wherever space you're part of, that you create safety. And one of the big things are safe bathrooms. So all gender restrooms, single stall, that should have a sign that says this is a space for all folks. And being careful and attentive and creating ways that folks can honor the accurate name and pronoun. That would be in the medical record. That would be in letters that are sent out to folks, or record summaries, making sure that you, and Juno Obedinalver, who's going to follow, shared that Juno puts at the top of the letter, that a consultation that she'll send out to a person who's receiving the record, will put the name and pronoun at the top, the correct name and pronoun. Make sure it's understood by all staff. This is extremely important, that, you know, front office, back office, the lab folks, the pharmacy, all your forms. If you you need to look through all your forms and your patient education materials and take away the he, she out. What's amazing is that it will not be missed, actually. There was a small study that happened with one of the Planned Parenthoods that found that out. So regular trainings, because things change, to make sure that the culturally respectful care is happening, and being willing to learn and change, the concept of cultural humility. Trauma-informed care is extremely important to integrate in, and that's a whole other talk, but then really recognizing the whole person always. And then doing the work to make these things happen. So it takes a lot. And this is one of the papers that I got to work on with Juno Obed-Meliver, a wonderful team with IBIS. And I highly recommend that you take a look at this article if you're in doing clinical care or doing research. So what does it take to build a gender inclusive clinical setting, and how can you conduct gender inclusive research? Moving to physical exam, recognizing that most folks have had trauma. Slowing down, be aware of your touch and of your approach. So ask permission, get consent before you begin your exam. Find out language for sensitive body parts. Many individuals use different words. Have a mechanism for inquiring about what words are used. So these are some examples: front hole for vagina. However, don't make an assumption and use the term front hole. You need to ask what term the person would want you to use. As Haas mentioned, having an anatomy or an organ inventory is a very important part of your both your intake and then your physical exam, to know whether there were testes or uterus and ovaries at birth, whether there have been any surgeries, and just having a way to get that information, whether someone still has chest tissue, for example. It's, I think, extremely important to establish trust before providing a genital exam unless it's requested. It's not needed for the initiation of hormones. And then Tandy and I have had dialogue over the years about ways to determine Tanner staging with a young person who may not feel comfortable yet for an exam, and yet to start a puberty blocker, you might need to know the Tanner stage. I won't be able to talk about body modification like binding, tucking, and silicones, but with the longer talk we would, but important to do. And then in alignment with the importance of primary and preventive care, to begin to have those conversations with folks about those screenings that will be needed. So moving to sexuality. As you can imagine, language is evolving, and we're seeing much more open gendered terminology for sexuality that doesn't require knowing necessarily the genders of the people that you're being sexual with, which is very liberating on the one hand, but then it may not support you in finding out what the risk of unintended pregnancy might be, or of sexually transmitted infection. So important to then inquire more specifically, and we'll get there. Sexuality, we found, often evolves with transition. And we need to learn how to talk about gender and sexuality with our patients in order to support talking about consent and boundaries and sexuality and what's actually happening. I love this resource written by trans folks, Safer Sex for Trans Bodies, and then a newer text that's just I think tomorrow being published, although some folks who ordered early got it. This is written by and for trans and non-binary folks, and it actually is for clinicians as well. So I encourage you to look at that. So here are some offerings for how to do a gender inclusive sexual history. Some of these questions are from the wonderful article written by Krapansky et al. That came out July 2019 in American Journal of Obstetrics and Gynecology. And some of these came from our article that we wrote together on the imperative of transgender and non-binary inclusion that I referenced before. So how do you have sex? Which body parts do you use? What fluids go where? Knowing about specifics of your sexuality can help you take better care of you, or we can work together on that. Do you use anything for pregnancy prevention? Do you desire pregnancy now or in the future? I already talked about language for body parts, but finding language that is comfortable for you as you work with your patients is really important. So I encourage you all to practice. And so this is kind of saying the same thing, but just a reminder that safer sex is a process and that we need to together journey to make that happen. Contraception, abortion services, self-abortion services. There's more, the miscarriage and abortion hotline, there's more efforts to get information to folks so that they can make informed decisions on their own. And a lot of these efforts now are really acknowledging the gender expansiveness of all of our patients. I know that we're going to be having a talk. I went faster. Going to be having a talk on family building. And the understanding that one can keep one's uterus as a trans masculine person is really important. Historically, trans men and trans masculine folks felt that after they'd been on testosterone, or had been told actually by their providers, that if they were on testosterone, they needed to have their uterus removed. And so many of the patients that I've seen over the years have moved ahead with a gender affirming surgery to remove their uterus, and then they learned that they could have kept their uterus. So this is a really important concept to recognize. And so these wonderful images, and I'm sorry that I didn't put the artist's name here, I will correct that. But it just shows you the mix or the many possibilities that in fact, even a couple of years ago were not possible because of reproductive assistive technologies. So on the left here is Tristan Reese with his partner Bill. And on the left, I guess I didn't write their names, a wonderful couple where her sperm contributed to the pregnancy for their 2 daughters. So when we think about youth, the decisions about whether one would move ahead with puberty blockers, which would then determine that, which would then essentially lead to immature ovaries and immature sperm that would not on their own be able to lead to future pregnancies. These are conversations that need to happen with young people and with their parents. And I'm now sorry that I removed so many of the slides. I went much faster than I thought. It'll be interesting to see. I'm very looking forward to the talks that'll be coming down the road, but we'll see whether at some point stem cells will remove all these difficult or make less difficult, currently difficult conversations. So this is a text Gender Quest workbook. It came out a while ago, but it really supports youth and their families to make decisions about surgeries, about hormones, about puberty blockers. So this just is my final slide to say, let's all work together. And next time I won't talk so fast. So thanks so much.